He's a bit older than I am, of course, but
Oh, of course.
yeah, but okay.
I think
I think that's. Oh, hang on. Yes, both slides are there, so that's good.
okay.
Which is the first one, Sandeep?
I think that's the first one. This one's fine.
Yeah.
I'll go ahead and get started. I hope they don't automatically advance. So thanks everyone for joining the neurology lecture series. I think it is automatically advancing. Do you know how to take that off of auto advance? Mark, if you just
I think once you go to my slides, it should be fine.
okay. If you can just go to the slide with the pictures. Thanks everyone for joining. This is the neurology lecture series, and we're honored to have Dr. Mark Parsons give a talk today on Tenecteplase and Alteplase stroke treatment. A little bit about Dr. Parsons. He did his bachelor's of medical science at the University of Newcastle, which I had to refresh my my geography of Australia, which is in the southeastern part of Australia, north of Sydney. And then he did his PhD at the University of Melbourne. He's a fellow of the Royal Australasian College of Physicians, the FRACP, and a fellow of the Australasian Academy of Health and Medical Sciences, which I think is very similar to our National Academy of Sciences. He's an internationally recognized leader in stroke medicine. He was most recently at the Royal Melbourne Hospital, where he was professorial chair of neurology at the University of Melbourne. And director of the Department of Neurology there. He's currently a professor of medicine and neurology at the University of New South Wales in Sydney, Australia. He's an acting head of school at the Southwestern Sydney Clinical School. He also has a lot of conjoint professorships in neurology at the University of Newcastle, interesting at Fudan University in Shanghai, which reading through his profile was very interesting because he's become fluent in Mandarin, which is very impressive. And he's published in a lot of stroke journals, really some of these pivotal papers on Tenecteplase, including the New England Journal of Medicine. And he's currently a PI in a phase 2 randomized control trial called TASTE-A, which is looking at Tenecteplase versus Alteplase for stroke thrombolysis evaluation in the ambulance. And this is all over Australia. And in terms of international academic collaborations, he's devised and leads this international stroke perfusion imaging registry, INSPIRE, with more than 20 centers in Australia, China, Canada, and India. And then has several ties here in the United States to Stanford University, and then in Canada, University of Alberta, UCLA, Cambridge. And just on a personal note, it was interesting to read that he's a cancer survivor, and it sounds like a very harrowing experience with AML and perspective on the patient journey. And I was lucky enough to see him at the International Stroke Conference give a great, pro and con talk on Tenecteplase. And since then, we've been trying to arrange this talk, and I'm finally glad that we're able to, because it's been quite in the works for a while. So with that, I'll turn it over to you, Dr. Parsons.
Thanks, indeed. Yeah, it has been quite tricky to get this together, given COVID and other issues. Yes, so thanks for inviting me. It's great to talk to you all. I'm sad that I'm actually not at Seattle in person, but one day I'm sure that will happen. I've had both of my Pfizer vaccines, so I'm fit to travel, but unfortunately our government won't let us travel just yet. I think we won't be allowed to travel until internationally, and probably until next year, unfortunately, because we're isolated and don't have much COVID. Our government's pretty strict on preventing spread and people bringing it back. Having said that, we did have a new bubble opened up with New Zealand yesterday, so we can travel between Australia and New Zealand freely without quarantine, which is good because that means we'll probably be able to go skiing in our winter. There's not much good skiing in Australia, but there's actually quite good skiing on the South Island of New Zealand, and very good Pinot Noir, which is a bit similar to Washington and Oregon states in the US. So I was looking forward to trying some of your Pinot Noir, but maybe we'll have to wait for a year or so. And just in terms of geography lessons, Sandeep, I'm not surprised you had to look up Newcastle. So there are two Newcastles. There's the very cold, miserable one upon Tyne in England, and Newcastle's actually very warm and on the ocean, and a lovely place to grow up, which is where I grew up and then went to university before I moved around. And behind me, actually, that backdrop is a vineyard in the Hunter Valley, which is just inland from Newcastle, and they also grow nice wines, although it's a bit warm to grow good Pinot Noir. We're better with Shiraz and Chardonnay. So enough of that stuff. And I should say that when I gave that talk at ISC a couple of years ago about Tenecteplase, I was on the pro team to say that we should switch to Tenecteplase. So of course, they say that a good debater can argue both sides of the topic. And I'll be less pro in today's talk, but you can see how it finishes when we get to the end. So this is the question: is Tenecteplase ready to replace Alteplase for stroke? I think you already saw my disclosures. I am on advisory boards for Boehringer Ingelheim, who actually make both Alteplase and Tenecteplase in all of the world except for North America, where it's done by Roche / Genentech. I have lots of different research partnerships with industry, but I would note that I'm not on the payroll of any imaging company, particularly perfusion software companies. So a lot of my colleagues that give talks, particularly North American ones, are on the payroll of one particular imaging company, but we're not talking so much about imaging today. So getting on to the talk, many of you probably all have seen this slide, and I'm not sure how many in the audience are not stroke trained or vascular neurology trained. And if you're more general internist, then this is a graph of the Alteplase randomized controlled trials pooling data from about 6,000 patients from multiple studies, including the NINDS study and the IST3 study and the ECAS studies. And this is showing the odds of an excellent outcome at 3 months with Alteplase compared to placebo. And you can see that over time, the odds of a favourable outcome with Alteplase drop off. And there are a number of reasons for that. And this is a graph that was originally developed by Jeff Saver at UCLA, showing you and to show to patients and their families. So for every 100 patients that we treat with Alteplase with ischemic stroke, about a third will get some benefit. They're the green patients. 3 will be harmed from brain hemorrhage, and then you see all the invisible or patients there who don't really get any benefit. And of course, there's more than one reason for that. One does relate to the time factor. So for those of you who aren't familiar, this is some perfusion CT, and the small, I'm not sure if you can see my pointer, but with the top left perfusion CT, you can see the large area of green, so that's tissue that's potentially salvageable, and then the small area of red, which is tissue that's probably irreversibly injured. And over time, what happens is the red infarct core area grows into the green penumbral area. So the later you treat, the more likely you are to treat patients with larger cores and less penumbra. But of course, it's nowhere near as simple as that, because the rate of infarct core growth depends very much on your collateral supply, which varies dramatically from individual to individual. So in fact, very early on, you might see patients with a very large ischemic core, which you won't pick on non-contrast CT, no matter how good you are at measuring aspects. And that's another thing, that in Australia, we don't really use aspects. We don't think it's much good. That's a topic for another day. So some patients who what we now call fast growers, their core will expand very quickly because they have poor collaterals. And then there are other patients whose core expands very slowly. So even at 5 hours or 6 hours or even later than that, they still may have lots of salvageable tissue and benefit from reperfusion therapy. But the other reason that there are a lot of invisible patients that don't get much response from Alteplase is the fact that patients with the larger clots, which we now call large vessel occlusion, don't often recanalize with Alteplase. And this brings me on to a brief sort of diversion into endovascular therapy, and you'll see why I'm talking about this, apart from the fact that it was another of our New England Journal papers. This time the study was run by Bruce Campbell with support from a cast of thousands, mostly Australians there. And the data from that study showed that this was one of the seminal studies showing that endovascular therapy was of substantial benefit for patients with large vessel occlusion, published in 2015 with a number of other trials. The first one was Mr. Clean, of course, the Dutch trial. And Bruce's trial in Australia showed that if you gave only intravenous Alteplase on its own, so half the patients were randomised to TPA alone and the other half were randomised to TPA followed by endovascular therapy, you can see that the rates of recanalization, particularly with terminal ICA or even M1 occlusions, the rates of recanalization at 24 hours, not early recanalization, were pretty low. And this is why one of the other reasons why Alteplase is not so effective, particularly in the most severe type of strokes. So this sort of led to some interest, obviously, in looking at other thrombolytics that might be more effective, particularly for those large vessel occlusions. And of course, there are other agents out there that have been trialled, including Desmoteplase, which showed a lot of promise, but again, without going too much off the beaten track, a large phase 3 study was negative with Desmoteplase and the company stopped supporting it, which was a bit sad because I do think it actually does have promise in terms of lysis. But moving back to Tenecteplase, it's actually, as you probably know, structurally very similar to Alteplase, but there are 3 particular molecular substitutions which might make it a more effective thrombolytic. And these relate to the fact that it has increased resistance to plasminogen activator inhibitor 1. It has a longer half-life, which means you can give it as a bolus. And I'll show you some information as to why that might be useful in stroke in particular. And it's more fibrin specific. So theoretically, it will cause at least less systemic bleeding. So this is data from the myocardial infarction trials, which were obviously done before any of our stroke trials with Tenecteplase, and pooled plasma samples of patients treated with Activase, it was Alteplase, versus Tenecteplase, and those lines that you see are the Alteplase 25th centiles and median values, and you can see pretty clearly that you give the bolus of the Alteplase and you get a pretty early peak level and then a plateau as you give the infusion for the next hour. But obviously the pharmacokinetic profile of Tenecteplase is quite different, and the line that I've superimposed there shows that you get a much bigger concentration of Tenecteplase in the first 15 minutes or so after the bolus compared to Alteplase. In fact, it tends to be about double the concentration of Alteplase, which might mean that you get earlier recanalization. At least that was the theory. So we thought that might be useful, particularly in stroke, where obviously we've got this issue of fast infarct core growth. And I can't say I was the first person to trial Tenecteplase in stroke, but Clark Haley and Pat Lydon, when he was at University of Virginia, and Karen Johnston did a trial of 4 doses of Tenecteplase. And I should just go back a step and say that many of you are probably aware that the dose of Tenecteplase for myocardial infarction is around 0.53 milligrams per kilogram. Interestingly enough, rabbit and rodent models of stroke suggested the bioequivalent dose of Tenecteplase getting similar effects to 0.9 equivalent of Alteplase in those models was only 0.1 milligram per kilogram of Tenecteplase. So Clark and team looked at 0.1 milligram per kilogram versus 0.2 versus 0.4 versus 0.5 in a non-comparative. There was no comparative group with Alteplase in that first study, and in fact, the 0.5 milligram dose arm was stopped early because of increased cerebral hemorrhage. But the three other doses, 0.1, 0.2, and 0.4, there were only 25 patients in each of those arms, so that they didn't actually show a difference in clinical outcome between the groups. Of course, in those days, pre-2005, not many centres around the world were using anything apart from non-contrast CT before treatment with thrombolytic, based on obviously the NINS trial and ECAS trials where that was the standard of care. So just to show a clinical difference with those small numbers would be nearly impossible without a lot of luck. So this was back in Newcastle, Sandeep. So there is that I was at there's only really one large university affiliated hospital in Newcastle, which is John Hunter Hospital, and we ran a small trial of Tenecteplase, and it was a bit game because we actually looked at Tenecteplase in the 3 to 6 hour window using the what I coined the dual target imaging selection approach. That was, I think, the first time that approach had been used. So patients had to have a vessel occlusion intracranially on CTA, and they had to have what's now called target mismatch on perfusion CT. So we actually treated patients outside of the standard time window at that time, which was sub 3 hours, because we had we really didn't want to deny eligible patients Alteplase at that time. So we went out on a limb and treated 15 patients with low dose Tenecteplase, and then compared them to patients treated over the same time period, which was about 18 months, I think, sub 3 hours with Alteplase. And in fact, we found that in that small study that there was a trend towards better recanalization and reperfusion. So we did follow up perfusion MR and MRA at 24 hours. And the Tenecteplase group seemed to have somewhat better reperfusion than the Alteplase patients, but of course the numbers were small. Then Clark Haley went on and did another study of Tenecteplase, and this time they went with 0.1 versus 0.25 versus 0.4 of Tenecteplase, but they had a control arm of Alteplase. I think again there were 25 in each group, but that was stopped early due to very slow recruitment, which was sad. So again, it looked like the 0.4 dose might have had a trend towards more hemorrhage. So based on those early results from, we also started a randomized controlled trial a little bit later, but before Clark's study had finished. So we weren't sure what the appropriate doses of Tenecteplase were either, but we also chose 0.1 versus 0.25, and we had an RCT where patients were randomized 1 to 1 to 1 to the 2 doses of Tenecteplase or a dose of Alteplase. And again, because of our philosophy of splitting rather than lumping stroke patients together, we wanted to try and select patients with the most potential to benefit from early reperfusion. So we again went with this dual target imaging selection approach. And that study, I'll show you some more results in a moment, did suggest that Tenecteplase at a higher dose 0.25 was superior to Alteplase. These were patients 0 to 6 hours, but all but 3 were in the 0 to 4.5 hour window, which by then was the standard time window for us, 0 to 4.5 hours for thrombolysis. Not long after that, the Scottish group led by Keith Muir did their own phase 2 study of a single dose of Tenecteplase, but didn't use what at the time was called advanced imaging selection. I don't like to call it advanced imaging now. I should say it's standard of care imaging, at least in some countries. We'll talk more about those results later. They didn't show any significant difference between Tenecteplase and Alteplase. Again, they didn't select patients based on a vessel occlusion and mismatch. And we can talk more about that later. Tempo 1 was a study from Sheila Coots and the Calgarians, looking at 2 doses of Tenecteplase in a slightly different group of patients with so-called minor stroke. NORTEST was a very large randomized study done in Norway, not surprisingly, of a high dose of Tenecteplase versus Alteplase using, again, only non-contrast CT to select patients. Again, our group led by Bruce Campbell ran the Extend I-ATNK study, which I'll talk to you more about later. And in addition, Ken Butcher's group at Edmonton ran a very small late time window study of Tenecteplase. So they're pretty much all of the Tenecteplase studies up until recently. And giving you a bit more information on our phase 2 study, basically what we did was try to select the patients with a small core and a large penumbra. So you can see there that the volumetric core was pretty small, around 10 mils in the 3 groups. So 25 patients in each arm, so not large numbers. And I mentioned the dual target approach. Now, we thought for those of you who know about golf, we were aiming for the sweet spot for patients who are the most treatment responsive to reperfusion. And this is the group who using the same figure I showed you before, have a small core and a large penumbra. And it seemed to work pretty well, that selection approach, because despite the small numbers, we found that there was superior reperfusion at 24 hours with the higher dose of Tenecteplase. So the graph on the left is showing you percent reperfusion at 24 hours with the standard dose of TPA. And you can see there's a large spread there. The median's around 60% reperfusion at 24 hours, but you can see that there are patients with virtually no reperfusion and there are a few with complete reperfusion. The 0.1 milligram per kilogram dose of TNK wasn't statistically different to the Alteplase dose, although it did seem that there was a bit of a higher rate of greater reperfusion, but pretty clearly the 0.25 milligram per kilogram dose of Tenecteplase, the majority of patients had almost complete reperfusion. You can see a few outliers there that didn't reperfuse. And then if you look at the graph on the right, this is the 24-hour improvement in the NIH stroke scale at 24 hours. And you can see it's like the mirror image of the reperfusion, which makes sense. So the patients that had greater reperfusion had greater improvement in the NIH stroke score. And again, this was significantly higher in the Tenecteplase 0.25 group. And in fact,
from what it is that the defense is trying to say.
Sorry, Dawn, you're not on mute. This 24-hour improvement also led to better 3-month Rankin outcomes. Now, I'm showing you the same slide from our phase 2 Tenecteplase trial at 24-hour reperfusion compared to the Extend IA trial from Bruce and our team in Australia. And the graphs actually for Alteplase obviously look pretty similar. So that's the big spread of reperfusion at 24 hours. And you can see, in fact, obviously the endovascular group had a lot of almost complete reperfusion with a few outliers where recanalization with endovascular thrombectomy wasn't successful. But it's important to note that both of these populations were large vessel occlusions. So our phase 2 were LVOs, predominantly M1s, with a smattering of M2s and terminal ICAs. So there are very similar populations. In fact, the Tenecteplase was almost equivalent at 24 hours to endovascular therapy. Then I talked about the ATTEST study. So that's myself and my 2 daughters and wife. My son's not in that photo. And Professor Keith Muir from Glasgow, who's a good friend. I don't have a photo of his family, but he's got a wife and 2 lovely children. What we did was we pooled the phase 2 data from our 2 studies, the Australian one and the Scottish one. We looked only at the 0.25 milligram per kilogram dose versus Alteplase standard dose because Keith's study didn't have any 0.1 Tenecteplase in there. And we then looked at how many patients had target mismatch, which was at the core of less than of 70 mils and penumbra of at least 10 mils. So I should note that in the ATTEST study, all patients had perfusion CT and CTA at the time of randomization, but it wasn't used to select patients. So as it turned out, more than 50% of the patients in the Scottish study didn't fulfill target mismatch. So it was quite interesting to compare the mismatch and non-mismatch groups. And in fact, quite a lot of patients didn't have a vessel occlusion. So you would suspect that those patients, you're going to struggle to show a difference in any thrombolytic or reperfusion therapy in patients without a vessel occlusion, I would suggest. So this is the pooled data of all patients at 0.25 of Tenecteplase versus Alteplase. And again, if there are people online that aren't familiar with the modified Rankin score, basically it's a measure of functional disability. Typically we use it at 3 months for our standard outcomes. So 0 is back to normal, 6 is death, 5 is severely disabled, a 1 is is still functioning normally. 2 is still a pretty good outcome, but typically we'd use 0 to 1 as an excellent outcome. 0 to 2 is a good outcome. And you can see here with the 3-month outcomes that even in the pooled group that there was a trend towards better outcome in the Tenecteplase patients, but it wasn't statistically significant. The shift analysis was 0.055 though. If you look only at the patients with target mismatch, you can see very clearly that there was a significant increase in Rankin 0 to 1, 0 to 2 with the Tenecteplase 0.25. If you look at other outcomes, particularly hemorrhage, it was interesting, in fact, that in the entire group and the mismatch only group, that there was less parenchymal hematoma, which is the bad type of hemorrhages. Symptomatic hemorrhage wasn't statistically significant, but the pHs seemed less with Tenecteplase. Then if you look at NOR tests, I won't dwell too long on this, but just to say that when you thrombolyze patients based on clinical assessment and non-contrast CT only, you'll get a lot of stroke mimics and a lot of patients with very mild stroke that perhaps don't need to be thrombolyzed. So it's no surprise in that study they had very high rates of excellent outcome because the natural history of patients with very mild stroke is very good. So again, it's pretty hard to improve on on the natural history in this group. And not surprisingly, hemorrhage rates were relatively low. So of course, my take-home message is that we should do perfusion CT in all patients, stroke patients. So this brings me on to ongoing studies of Tenecteplase. So TASTE is our phase 3 study of Tenecteplase versus Alteplase, which has been going for quite a few years now. And thrombectomy obviously slowed our recruitment substantially. So the study started just before the seminal 2015 thrombectomy patients. And I'm sure we would have been finished a long time ago if thrombectomy didn't come along, but it's obviously good for the patients, not so good for this study. So this study was looking at all patients eligible for thrombolysis in the 4.5-hour window, but with the additional criteria of needing a mismatch on perfusion imaging. We did originally allow MR, but in the vast majority of our centres, it's CT because it's quicker and more accessible, as you know. Patients randomised 1-to-1 to standard dose TPA or Tenecteplase. Primary outcome ranking 0-1. Current samples 728. We use MyStar automated software to calculate call per number, which gives us an output, which you can see on the left. And in fact, the software even tells you whether or not you should randomise. Of course, you would probably know if you use other software, but including this software, you shouldn't always necessarily believe the volumes that come out. But if you look at the raw perfusion maps, which are the top part there, so there's cerebral blood volume, flow, mean transit time, and Tmax, you can pretty clearly see that the data quality is good. So you can probably trust the output. So that's a target mismatch patient. This is a patient who's still got some penumbra, but has a core there of 97 mils. So they're ineligible. Whether they benefit from any form of reperfusion therapy is interesting, and again, topic for another day, including endovascular therapy. So the study, despite all of the obstacles, is still enrolling, and we're currently up to 526 patients with an interim at 546 patients to work out what our final sample size is and whether in fact we can stop. Despite the fact that endovascular therapy came in, we've still got quite a lot of M1 patients, almost 40%. But you can see the baseline NIH is only 8, which is much lower than in our phase 2 studies and in the endovascular studies, meaning that a lot of the patients have more distal occlusion. So again, finding an improvement from Tenecteplase over Alteplase might be tricky, but we shall see. It's across quite a lot of countries, predominantly Australia, but a couple of Canadian centres, a couple of pretty good British centres. They're a bit hard to find when you mandate perfusion imaging, because a lot of the British centres are pretty, what's the right word? Well, those of you who've worked in the NHS will know what I'm talking about. We've got Spain, some Spanish centres, including Carlos Molina's centre, and we've got quite close links with Taiwan. In fact, the photo I showed you there earlier of my family, my wife, Taiwanese, but we've got close academic links too. The Kiwis, particularly in Christchurch in New Zealand, recruit quite well, which is good because they're quite close to the ski field. So I like to make site visits there. And we've got a couple of good recruiting sites in other parts of Europe as well. The top 10 include my old centres of John Hunter and Royal Melbourne. Box Hill's another great recruiting centre, as is Royal Adelaide. Then we've got Cambridge, which is the top UK centre. Liverpool, which is where I'm at now, is moving up the charts. In fact, we recruited another patient just before midnight last night. So we're 29 now, so we'd be equal fifth now, fourth, equal fifth. Then you can see we've got Spanish, Taiwanese sites, and Christchurch there at 10th. So next, there have been a number of meta-analyses come out around Tenecteplase versus Alteplase for stroke, including Jeff Saver's group in stroke 2019. And this used studies from data from a number of studies, including our Aussie studies. The results were strongly driven by the phase 2 Australian studies, which I think you need to keep in mind. And I have to claim partial responsibility, I guess, for Tenecteplase having a lot of enthusiasm for its use, and we'll talk more about that later. But this meta-analysis was based on non-inferiority with a pretty lenient non-inferiority margin. But you can see that the 0.25 milligram dose does look to actually have a trend, does look to favour Tenecteplase, but it certainly was non-inferior. And safety, there's certainly no significant difference in major hemorrhage. Again, it was interesting that the more evidence from the meta-analysis for benefit at the 0.25 dose, which, as I alluded to, was driven by our 2 Australian studies. The Nortest 0.4 milligram Tenecteplase obviously didn't show, wasn't as strong in favour, again, for reasons that we've talked about. But I'll talk a bit more about the Extend-IA case study, because it's interesting to look at that data, obviously, or the 2 studies now, and then talk a bit about what's happened as a result of these studies, in particular the meta-analysis and guidelines around the world, including in Australia and the US. So that's Bruce. He generally looks pretty serious for those who know him. So this was a study basically in patients going to thrombectomy, and we randomized patients to standard dose Alteplase or 0.25 of Tenecteplase, and a primary outcome was actually the baseline Tiki score at angiogram before any attempted clot retrieval. This study, just move on, had 101 patients in each arm. You can see the NIH score was quite high, which would fit with an LVO study. This particular study, there wasn't a lot of drip and ship from primary stroke centres, but you'll see that was different in the part 2. And you can see the spread of occlusions, predominantly M1s, but quite a lot of ICAs and a few M2s. So this was the primary outcome. You can see very clearly Tiki 2B or 3 at baseline angio. The first hurdle was non-inferiority, which was proven, but it was also superior in terms of substantial reperfusion at baseline angiogram. 22% had Tiki 2B3, Tiki 2B or 3 with Tenecteplase versus only 10% with Alteplase. And I was somewhat surprised that that translated into actually a shift in better outcomes on the Rankin scale, because all patients went on and had thrombectomy anyway, but obviously the earlier reperfusion with the Tenecteplase must have translated to less infarct growth and better outcome. And then Bruce and our teams went on and did part 2, which was more recently published, and that was looking at 2 doses of Tenecteplase, and there's some more hot off the press data that hasn't been published that I'll tell you about from this study too, which is of interest to you, I'm sure. So the study design was more or less the same as Extend-IA part 1. And there are quite a lot of centres in Australia and New Zealand, or one in New Zealand, our good old Christchurch again. By this stage, the mobile stroke unit was up and running in Melbourne. So it was actually the highest recruiting centre for Extend-IA because we had CTA on board, so patients were randomised in the Extend-IA 10K Part 2 study on the ambulance based on presence of LVO in the ambulance, and then obviously were taken to the nearest comprehensive stroke centre for clot retrieval. So patients were randomised to the 2 doses of Tenecteplase, same study design as before. And in fact, the outcomes were almost a mirror image of the 2 doses, a bit higher numbers. And in this study, there was more drip and ship because we had more primary stroke centres, which is interesting, because you would think that when there's a longer gap between lysis and thrombectomy, you might give the lytic more chance to work. The primary outcome of that study, as I said, was a mirror image. There was absolutely no difference in early reperfusion on baseline angiogram between the 2 groups. This was quite interesting, and the result there, 19%, was very similar to that seen in the Extend-IA Part 1 study, where we were 22% with the Tenecteplase dose. Of course, so that didn't translate into any difference in clinical outcome. There looked to be a trend towards excess hemorrhage in the high dose of Tenecteplase, but it wasn't significant. But in fact, one of Bruce's PhDs has just looked at the data by age, and most of the hemorrhages at the high dose of Tenecteplase are in the over 80-year-old groups. And when you actually look at the over 80s in this study, of which there were over 100 patients, which is quite a lot. And sometimes I raise my eyebrows at the age of the patients that were randomized into this study, but that's another story. The 80-year-olds in this study actually had excess symptomatic hemorrhage at the 0.4 milligram per kilogram Tenecteplase dose and higher rates of mortality, even though overall there was no significant difference in this study. That'll be published soonish, I'm guessing. The Extendo part 1 was pretty convincing, but clearly to show differences between two doses of Tenecteplase with clinical outcomes would require massive sample sizes, which we weren't obviously going to ever complete. So it does look like 0.25 is probably the right dose for stroke based on that data. I've talked about that already. And then I'll just quickly mention the study that Sandeep said, TASTE A. So in fact, Sandeep, TASTE is the study we're doing all around Australia and other countries in the world. TASTE A is currently only on the Melbourne stroke ambulance because there is only one stroke ambulance in Australia currently. We're getting one in Sydney next year, I think, by which time TASTE A, which is really a phase 2 safety trial in the ambulance, will be completed. The sample size is 120 patients. We've already enrolled 80 patients to Tenecteplase versus Alteplase on the ambulance, but unfortunately we don't have perfusion on the ambulance yet. Hopefully that'll come with version 2 next year, fingers crossed. So just to summarize, I've got a little bit more after this, but this is to summarize what we know with all of those results. Clearly, Tenecteplase is more convenient because it's a single bolus, and it's much easier to give drip and ship patients clearly. And in fact, in Australia, I'm not sure in the US, when we bring patients in on the stroke ambulance on an infusion of TPA, we actually have to change it over in the ED that we arrive at because they won't use the same infusion that started in the ambulance for bureaucratic reasons, would be how I'd explain it. So there is mucking around, and there's potential for dosing errors there when you change over. It looks like, as I showed you, that prior to thrombectomy in LVO, that Tenecteplase might be superior, at least for early reperfusion. But I would say that there's not been a phase 3 trial yet that shows that Tenecteplase is superior to Alteplase, let alone non-inferior. I guess that's where TASTE will come in. I should mention that Keith Muir's doing a similar phase 3 study in the UK, predominantly in Europe, but not using a modern imaging selection, just non-contrast CT. So that's looking at non-inferiority. We don't know about the late time window, and I'll talk to you a little bit about that. And in fact, prior to COVID, a couple of Australian states completely replaced Alteplase on their drug formularies with Tenecteplase for patients with LVO, but then it sort of crept into almost all stroke in some centres. New Zealand did the same, and there's a number of generic Tenecteplases around the world that are being used either because they're licensed, like in India, based on minimal data, I might say, and there are at least 2 generic Chinese-produced Tenecteplase currently being trialled in China, and we're not really sure that if they're bioequivalent to the Genentech/Boehringer Tenecteplase. So, funnily enough, because both Tenecteplase and Alteplase, for that matter, have a fixed supply because of the way it's produced with recombinant DNA technology, it takes probably 3 years lag to increase the production because you need to build more of those vats where you have the bacteria that produce the alteplase and tenecteplase, because of its fixed supply, the increasing use of tenecteplase in a number of countries, including Australia and Europe, because they're using a lot in France too, off-label for stroke, led to a major shortage. Now, apparently it's not the same in North America. Genentech have managed to I'm told, don't have the same shortage. But in Australia, we were told by Boehringer that we were likely to run out completely in the middle of 2020. And part of the reason for this was during COVID, a lot of sites completely switched to tenecteplase. I don't really totally understand why, apart from it being more convenient. And I think they use COVID as a bit of an excuse to switch to tenecteplase because of all the enthusiasm about it. And this had flow-on effects in MI because, in fact, as you know, the only proven phase 3 data for tenecteplase is actually in MI. And in Australia, a lot of patients is treated with tenecteplase because they're remote to angioplasty centres, particularly in rural Australia. It's given in the ambulance after an ECG. So this led to major problems. Shortage of tenecteplase. Most paramedics had never given Alteplase, so they had to be trained in how to use it. It's caused a lot of trouble in Australia, so we ended up writing an editorial about it. And subsequently, tenecteplase has been banned in New Zealand for stroke because of the shortage, which has led to a number of my New Zealand colleagues not talking to me for a while. Obviously, I and Chris Levi had a vested interest because we were running a phase 3 trial of tenecteplase and wanted to finish the trial and didn't want to see all of these patients that should have been randomised into TASTE getting open label tenecteplase. And then finally, I just want to talk to you about the extended time window because we're now doing trials of tenecteplase and you'd be familiar with the Timeless trial. I'm not sure if you're involved in it in Seattle, but we did the Extend IV trial, which went on for quite a few years, using perfusion imaging selection, predominantly CT, although we started off with MR, but recruitment sped up once we had perfusion CT going. And that was looking at extending the time window for Alteplase up to 9 hours for no onset stroke. And for wake-up stroke, we had a funny definition, but it ended up being up to 12 hours after the midpoint between last seen well and presentation time. And we showed in a relatively small study of just over 200 patients that there was a 3-month improvement in excellent outcome with Alteplase compared to standard of care in patients with target mismatch. About 2/3 of the patient had LVO as well. So that then led us and also Greg Albers in North America to look at tenecteplase in the later time window. So our studies are Greg's is 3 to 24 hours, I think, using target mismatch, tenecteplase versus no lytic pre-thrombectomy. Our study was a bit different. We decided to, and because our guidelines had already changed around late time window thrombolysis, we've gone with tenecteplase versus standard of care in patients. So that standard of care might include Alteplase. It's totally up to the investigator if there's target in the presence of target mismatch. So, and we've gone for a full time window 0 to 24 hours because we wanted to get more LVO data in the early time window because, again, there's no phase 3 data for any stroke patients for tenecteplase available. This study only started in the middle of COVID, so recruitment has actually been pretty good considering that. It's a large phase 3 study of target mismatch and potentially retrievable thrombus at the time of randomization. Basically pretty standard inclusion criteria. Just to mention, premorbid Rankin, which is a pretty not designed to measure it's used in trials now to select patients who've got significant pre-stroke disability, but it's not designed for that. So we don't like it much, but we use a thing we call the DBS, and not deep brain stimulation, driving, banking, shopping. I think that's actually a pretty good measure of pre-stroke function. So patients need to be what we call DBS positive to be eligible for the study. And we've only been going since mid-2020, and we've already recruited 50 patients with just 7 sites on board. We're currently bringing on another 10. We're trying to get a lot more telestroke sites up and running. So I think by the end of this year, we should have up to 50 sites in Australia and New Zealand, but we are going to roll out hopefully next year. COVID slowed everything, of course, internationally, where COVID's obviously hit countries a lot worse than Australia and New Zealand. But it'll be fully up and running, I think, by the end of the year. So yeah, we've recruited quite well. In fact, half of those patients are in the sub 4.5 hour window, which is interesting. So again, just finishing off, we know Tenecteplase is more convenient to give, probably doesn't increase hemorrhage, and looks like it has earlier recanalization based on the LVO data. But we really don't know if it's superior or even non-inferior to Alteplase from any phase 3 data. Yes, the meta-analysis shows that it's non-inferior, but there's no phase 3 data in there. So I actually suggest, and as we said in the editorial, that it's premature to switch to Tenecteplase. We call it premature translation. And I thought that might have been edited out in the article we wrote, but it wasn't. Anyway, so I guess I'm a bit balanced and a bit ambivalent on whether we should be using Tenecteplase. But again, you would note my conflict says that we're still doing phase 3 trials and we want to get the trials done. So I'll stop there, and thanks very much for listening.
All right, thank you so much, Dr. Parsons. That was a great talk. I've asked folks to unmute themselves and ask questions. I'll just start by asking, has there been a push in Australia from the emergency medicine side to make this transition into Tenecteplase because of the ease?
I would say, good questions, Andy. I would say not so much from the emergency physicians, but particularly push from our smaller, more rural/regional hospitals, because Alteplase is only used for stroke now in Australia. So a lot of the smaller hospitals have only Tenecteplase in their stock because it's used for MI. So there was more of a push from the smaller telestroke sites because of the concern about, because they use Alteplase so rarely, they're worried about dosing errors and etc. But so again, so it's more based on convenience, I would say, but not so much from the emergency physicians. Again, in Australia, a bit, I guess, like in North America, there are still a reasonable number of emergency physicians who don't believe thrombolysis works for stroke. So they're skeptical about any thrombolytic data. And in fact, ironically, probably what's convinced a lot of Australian emergency physicians that lysis does work for stroke is actually the perfusion imaging. They really love it. I mean, they can't really interpret it, but it's defeated their argument that we're treating patients that are TIAs, one of their arguments, or stroke mimics at least. So it's interesting the mindset of emergency physicians. I don't know if there are any online.
There might be, I'm not sure. And then any other questions for Dr. Parsons, please just unmute yourself, or you can type in the chat.
I should just say, sorry if there was a bit of noise in the background. My dog was yawning because it's pretty early here in Australia. It's about, well, it's nearly 6 a.m.
I should remind people that Dr. Parsons had to get his coffee from McDonald's today because it was the only place open at 4:45.
Yeah, exactly. So, and I thought originally the talk was at 6 a.m., but our daylight saving ended last weekend, so it's bad timing.
Yeah.
Now,
I've got a question.
yes, David.
Yeah, thanks. Great talk. Really
Thank you.
interesting and timely and controversial, at least over here at this point.
Yeah.
Seems like a lot of the work that you talked about was focusing on the LVO subgroup and or extended time windows, but obviously a lot of Alteplase is given in the 0 to 4.5 without any special imaging.
Totally.
And so where do you, in that group, where do you think the difference is, and what trials are focusing on answering that question?
Thanks, David. So there, I mean, I guess TASTE is predominantly looking at that group because most of the patients in TASTE don't have an LVO, so at least 2/3. They still, however, do have at least 10 mils of mismatch, but that's pretty small. So in fact, looking at the imaging data from that study, most of the patients have perfusion patterns that are consistent with like M3, M4 occlusions, and for those of you who do look at a lot of perfusion, it's much easier to see a distal occlusion on CTA like an M3 or an M4 if you know where the perfusion lesion is. You can go back and check it. So a lot of these patients have very distal occlusions. And so TASTE will give us a lot of information on that group. The other big study that's looking at that is the ATTEST-2 study run in the UK by Keith Muir, which is, we won't know so much about the pathophysiology of these patients because they're not doing perfusion CT and CTA in that group, only non-contrast CT. And then, of course, the NORTEST study, which is already completed, enrolled over 1,000 patients who would be the classic group that you're talking about, David, non-LVO, sub 4.5 hours, and they found no difference of Tenecteplase. But this is the issue, and it is controversial in many ways when I talk about that group of patients, because it's clear that we do treat patients with that are mimics. If you look at the NORTEST data, it was 20%. And if you don't use perfusion imaging, of course, you probably don't harm them, but to show a benefit when you're diluting your sample with mimics and patients with very small distal occlusions, I reckon it's going to be very hard to show a benefit compared to Alteplase. There are a couple of big studies in China as well with generic Tenecteplase. They'll probably end up beating us to the punch and finish before us. But David, we don't really know what the effectiveness of Tenecteplase is.
Thank you.
There's a typed question for hospitals considering implementing the use of Tenecteplase. What are your recommendations?
It's interesting because we're currently talking with Boehringer Ingelheim about, because they're very keen to put in a licensing application for Tenecteplase for stroke when TASTE finishes. And we've had a lot of discussion about, oh, well, look, you're using perfusion imaging to select, so should the licensing criteria mandate that? And so there's lots of questions around that. So look, I would say to you, there's not really enough data to switch unless you know there's an LVO at a minimum, I would say. Like, I mean, I think the data for large vessel occlusion is relatively convincing. So I'm not sure that I would be pushing towards switching at the moment. But having said that, I think your American guidelines are probably the least strong towards Tenecteplase compared to around the world. The Australian guidelines are very strongly in favour of Tenecteplase for any thrombolysis eligible stroke, which I don't necessarily agree with, but you might be interested to know that the chair of the guidelines is Bruce Campbell. so he's a slightly differing opinion to me. And in the US, I don't think he would be allowed to be in charge of that guideline committee, but our rules are a bit different in Australia. So, I mean, that's a pretty roundabout way, I guess, of saying I think it's pretty tricky to decide to switch to Tenecteplase at this point in time. I think we need more data. The reason sites have argued switching pre-thrombectomy is based on Bruce's LVO data, but also the LVO data from our earlier Tenecteplase study, I guess.
But if you had to pick a dose, would you go with the 0.25?
Yes, particularly given that data that's not yet published, but it will be, that does suggest increased hemorrhage particularly in older patients.
Yeah, it sounds like you're saying it's not quite ready for prime time, and the idea of giving it just in LVO patients, as you mentioned, our American Heart Association guidelines are a bit conservative, and we can thank Dr. Tershwell for that.
I think appropriately. Oh, good, very good. I didn't realise. Yeah, I think appropriately conservative.
Yeah. Any other questions from the group?
I should just say, well, perhaps David could have an influence on the guidelines around perfusion imaging in the early time window, because I know it's not recommended in your guidelines. It certainly is in ours. Well, it's said that you should consider doing it, I think.
I think it's a really interesting question.
Yeah.
You know, a lot of people worry about the time delays and things like that, but my personal feeling is that while you're mixing and putting on an IV pole and stuff,
Totally.
you'll probably be most of the way done with your perfusion imaging. And even
Yeah.
if you stop at 5 minutes in because there's nothing to see, you're probably decreasing risk for a lot of people.
Yeah. Yeah, I think once you're up and running and doing it routinely, the time delay is minimal, actually. In fact, a lot of the time we see the perfusion maps come up on our email before we're called about the patient from our fellows.
All right, well, thank you very much. And Dr. Parsons has been nice enough to meet with our stroke fellows here this afternoon, despite the early morning there, and we appreciate that as well. Thank you, Dr. Parsons, very much for a great talk and great discussion. And I'm really glad we were able to do this,
Yes.
all this planning. All right, take care.
Thank you. Bye-bye, everyone. Bye.